I've got a subject this morning that is one of those really tricky ones to have a reasonable, rational, and fairly calm conversation about, generally, because of the sensitivity of the subject and what it evokes for certain people. So something I've been dealing with in the background here for a while now has been involving elderly people and infirm. But elderly people who are basically effectively already dead, but for some reason, society and culture and family likes to keep them alive. So this is why this is such a sensitive issue. And you can imagine it's a really tricky situation. If I give you some examples of the kind of thing that I'm talking about, because I can't really go into any specifics, but when I was a nurse, I did a lot of work in various care environments for elderly people. And some of these people were essentially brain dead. There was very little function going on at all, with brain deterioration in varying conditions of whether it's post-stroke or CVA, whether it's dementia or Alzheimer's, and the whole range of degenerative brain disorders. And some of these people were essentially what we would call grinders. They would be in bed, never conscious, never moving, no self-care whatsoever, no ability to interact. Family at this point have long stopped visiting. And essentially our job was to feed them and give them the medication, keep them clean, maintain any comfort if there was any discomfort issues, and so forth. But it struck me as odd that sometimes a patient who's in this state would get a chest infection, and it would be a very obvious chest infection, and we'd give them antibiotics. The diabetics would give them insulin. The people with blood pressure issues would still be giving them their blood pressure medication every day. And I had to raise some questions as to why are we doing this? Because the labour-intensive aspect alone for the amount of staff and resources employed nationwide is enormous. And it seemed that those resources are only finite, where is care not being given that could be given in place of this. But more importantly, it seems to me that this wasn't in the best interest of the patient, and it didn't appear to be in the best interest of the family either. Before I did all that kind of work, I worked in accidents and emergency, as I know some of you will be aware of, and I did a lot of resuscitations in accidents and emergency of people in cardiac arrest. Now, very, very few patients who have a cardiac arrest outside of a clinical environment will even survive the trip to the hospital, let alone actually ever leave hospital at the end of it. And some people do survive, but they are the tiny, tiny minority. So questions I used to have then, as well as did many of my colleagues, is why are we doing this? Because a lot of these patients in their last dying moments are being subjected to fairly invasive, fairly brutal resuscitation efforts that break bones, tear apart veins, and do all sorts of things that we do in the pressure to try and save the person. And a lot of these people are actually dead. They haven't succumbed to a recoverable medical condition. But now everyone is subject, it seems, to resuscitation. And a lot of the staff had the same opinion that I did, which was they wanted to get a tattoo that says "Do not resuscitate" across their chest, so they would never be subjected to that themselves. Now, the question for me also comes to, what happens to the ones who do survive? Now, we know of plenty of stories of people who have undergone resuscitation, they've subsequently recovered, and they have a story to tell. Most of those, of course, actually had their cardiac arrest inside a clinical environment, not outside. A lot of those people that actually survive are never walking and talking again. They become a grinder. And the grinders are people who essentially are so brain damaged by anoxia, or hypoxia, whatever the term is, that they never have any form of function whatsoever, and they just lie in bed and grind their teeth. Now, to give this a context, I worked in a very short period of time, it was over a summer period, when I was a student in these are awful terms, but it was called an allotment. And the allotment is eventually the vegetable patch. And it's one of those colloquialisms that staff use, sort of the black humour, but also at the same time, you know what you're going to when someone says that's an allotment. Now, this was an old country manor house that had been converted to a clinical environment. The clinical environment now was a warehouse for people who were brain dead, who had survived resuscitation. And horror of horrors, I mean, this is the only place like this I've ever set foot in. You essentially had one great big hall, And down one side you had a row of beds, and down the other side you had a row of beds. And these patients are in a A-frame, which is like on a hammock. And on the hammock, you've got a roll system, so you can literally. It makes it much easier to turn a patient when you only have one member of staff to do it. And essentially, my job was to be feeding and watering people, all tube feeding, and crank the handles as I would go up one side, down the other side, to stop them getting pressure sores. And some of these patients have been there for years. They'll never get out of that bed, out of that hammock, and they'll be grinding their teeth constantly. Now, this is absolutely horrendous. This is just an awful existence for those individuals if they have any awareness of it. But also the protracted suffering for the family too is horrendous. So the question is, why do we do that? And I still don't really have a satisfactory answer. This probably is multifactorial. And then the question is, if we don't do that, what do we do instead? So do we now keep people comfortable? I understand the arguments against things like euthanasia, but do we now stop doing things like giving blood pressure medication, antibiotics, insulin, and so forth to people that have no hope of recovery and are completely out of it? Then, of course, we hear the story, which is always the counterexample of the person who's been in that vegetative state, who's come out of it, and then they tell the horrible story of their 20 years in the twilight zone of being unable to communicate. And, of course, then there's always the what if. There's always the counterexample. And then there's the slippery slope argument, which is, okay, so if we start here, then where does it stop? Do we start euthanizing disabled people and people with other disabilities and mental issues? Where does it stop? And so these are quite valid arguments. But at the same time, I can't help but think, if I was one of those people myself, would I want to be kept in that position because of the potential what-ifs? So I don't have any answer or philosophical position as to what should be done. I don't have an alternative. But I do know that what I witnessed firsthand, what I have perpetrated myself firsthand, was absolutely just awful. And it's got to be something better than that. I just have to finish with one story, which I think was the worst thing I ever experienced in my life, actually, in every possible way. And a number of other colleagues who were there at the same time also had the problem. And there were people who took over this patient's care after us, and I'll tell you the story in a second, who I also know suffered a lot of problems. So to cut a long story short, we were once presented with a gentleman who had a very late stage degenerative neurological genetic disorder that had long been identified. It was an inherited condition, and he had always known that he was going to end up, unfortunately, dying very early through horrendous genetic deterioration that affects the nervous system. I can't go into what the diagnosis actually is. Now, he was now at the point where he requires full care, and after the carer had left, he had managed to take an overdose, and it would have been a fatal overdose. Now, this man is completely neurologically ruined. He has no hope of recovery and no hope of ever having any comfort. His whole life was one of suffering now. He'd taken an overdose, and unfortunately, the carer had returned, having left something behind, and had found him. Carer phones an ambulance, and now he comes to us into the resus room. Now, we know the backstory. The carer has given us the backstory. The paramedics have given us the story. We've already got his notes before he's even arrived because it's been phoned ahead. And, of course, now, quick debate. What do we want to do? Well, let the poor man die. What do we have to do? We have to wash him out, and we have to resuscitate. So effectively, now what we did was we now forced the man to live, knowing that he'll probably die in a couple of weeks again anyway. And he unfortunately regained consciousness with us. As you can imagine, he was not very happy. And then we send him up to the ward against his wishes, because now he's in a situation where he cannot actually get himself up off the bed. He can't do anything. And against his overt wishes, we send him up to the ward. And of course, the ward now have to continue the treatment for the overdose he had taken. The law required us to do that, and there was nothing else we could do. And sure enough, the man eventually actually never made it back home again from the ward. He died up on that ward about 2 weeks later, as we fully expected him to do so, even if he hadn't taken the overdose. So effectively, we've allowed the man to die twice, except the second dying took a lot longer and was a lot fuller of suffering that he never wanted. what do we do in those situations? These are horrendous ethical situations. They're horrendous ethical considerations to make. We have all of the arguments against, but what about the individual who's trapped into that system? And also the consequence this has upon the caring staff and the families, who are probably not necessarily aware of the bigger issues. They're just doing the job a lot of the time. But the families, of course, are going through this, and they don't know that actually this is wrong, because they're only being told the clinically dressed up story, which is usually sanitized to alleviate a lot of the distress that comes with that. So I'll be interested in what you have to think. Do please leave any comments for and against, any arguments you have in the comment section. I would be interested in your point of view.